Good evening and welcome to session 2 of our virtual patient education series, 2020 New and Emerging Treatments for Blood Cancers. My name is Carrie Callis. I'm the Director of Programs at the Leukemia Research Foundation. We are pleased to present this event in partnership with the Cardinal Bernardine Cancer Center at Loyola. We're grateful to have our presenters this evening, Dr. Sonali Smith and Dr. Nasheed Hossain. We would also like to thank our supporters of this program, AbbVie, Jazz Pharmaceuticals, Karyopharm Therapeutics, and Novartis Oncology. As a brief background about the Leukemia Research Foundation, the Foundation's mission is to conquer all blood cancers by funding research into their causes and cures and enriching the quality of life of those touched by these diseases. Since its inception in 1946, the Foundation has funded over $80 million of research grants to over 500 new investigators on 5 continents and supports patients and families living with a blood cancer diagnosis through educational and support programs. I encourage you to visit allbloodcancers.org to learn more about our patient support programs, including our online support community and our comprehensive listing of resources. So at this time, I would like to introduce our moderator of tonight's program, Dr. Patrick Stiff, who is the director at the Cardinal Bernardine Cancer Center at Loyola University. He's the chair of the Foundation's Medical Advisory Board, and we thank him for all he does to advise and support our work at the Foundation. We are going to start with by introducing Dr. Sonali Smith from University of Chicago. Dr. Smith, welcome. And if you could just say a few words and go ahead and start your presentation.
Absolutely. Thank you so much to everybody for having me here. Thank you, Dr. Stiff, for inviting me. I have participated in the live event several times and really enjoy and appreciate all the great questions and all the interest. And I'm very grateful that all of you are here tonight to talk a little bit more about lymphoma. So I was tasked with talking about aggressive B-cell lymphomas. And what I thought I would do is give a little bit of a primer. I know that normally when we meet, it's not really a lecture. It's really more, discussing questions and things like that. And I think for this particular group, I don't know that I've ever really been able to go over some of the basics, but I thought it would be a good way to set up the next presentation, which I'm really excited about. So I'm going to talk about aggressive B-cell lymphomas and give a bit of a background. I think I know, or at least I've been at this before, but just for those of you who don't know me, I've been at the University of Chicago for 22 years now and director of the lymphoma program for the last 10 years. So this and CLL are 100% of what I do and really have a passion for trying to figure this disease out. So I'll start with what is lymphoma. Lymphoma at its core is a family of blood cancers derived from mature lymphocytes. Lymphocytes, which come in 3 flavors, 2 flavors, B cells and T cells, but then there's another part called NK cells, which are also part of our immune system. These cells normally fight off viruses, bacteria, fungi, and foreign organisms. They have access to the entire body by traveling both in the lymphatic system, which is a system of tubes that are very closely aligned with the circulatory system, and they have access to really every part of the body. So they can grow in lymph nodes, and then we call it nodal, or they can grow in non-lymph node areas, and we call it extranodal. When it comes to putting lymphoma in context, we know there's about 1.8 million new cases of cancer in the United States per year, and non-Hodgkin lymphoma currently ranks as the 7th most common cause of cancer in both men and women. This translates to about 80,000 new cases per year, and we've made a lot of progress, but we do lose about 20,000 patients per year, and this is an important inspiration to try to improve upon. But the difference between the new cases and the number of people not surviving means that there's over 500,000 people who are living with lymphoma. Importantly, lymphomas affect both genders, all races, and all ages. So what causes lymphoma? We don't know in an individual all the time what causes it, but we do know that increasing age, abnormalities of the immune system, whether it's inherited abnormalities related to treatment of another condition like an organ transplant or acquired like HIV, do increase the risk. We know that there are some viruses, some of which I've listed here, chemicals and bacteria, all of which have been linked to specific types of lymphoma. What we don't know is the impact of genetics, environment, diet, and lifestyle. And these are areas of active investigation. And in particular, I think the impact of genetics is going to be very important over the next decade as we learn about some of the mutations that might increase the risk of developing lymphoma in certain families. When we put it all together, there's about 80 to 100 different subtypes of non-Hodgkin lymphoma, and I've put the lymphoma pie up here that gives you an idea of how common some of these lymphomas are. So diffuse large B-cell lymphoma is the most common, accounting for 30% of all lymphomas, followed closely by follicular lymphoma. And then we have a number of other lymphomas, which are much less common, but nevertheless something we see on a regular basis in a lymphoma clinic. So how do we make sense of all of these lymphomas? Well, one way to organize them is to look at their expected clinical behavior. So we know that despite being 80 to 100 different flavors, that in general, these lymphomas fall into one of three categories. They're either low grade and indolent, intermediate grade or aggressive, or they're high grade and highly aggressive. Low grade or indolent lymphomas are slow growing, they're incurable, happen to occur more commonly in older people, although about 1/3 to 40% of people are under the age of 60. But these are things that grow so slowly that they are diseases that people live with, often for decades at a time. The aggressive lymphomas are faster growing and ironically potentially curable and can occur in all age groups. And then high grade or highly aggressive lymphomas are very fast growing, and some of these, such as Burkitt lymphoma, are highly curable. Now, this framework is really important, and you've probably heard your doctor use these terms, but what's important to know is that it's not particularly complete. And there are some lymphomas, such as mantle cell lymphoma, which are both incurable and fast growing, or T cell lymphomas, which are often very fast growing and challenging to treat. So the topic that Dr. Stiff asked me to focus on is an aggressive lymphoma. So let me define that a little bit. An aggressive lymphoma is a lymphoma that grows quickly and it needs treatment either urgently or emergently. Most patients present with symptoms. These are lymphomas that people come to medical attention saying, I don't feel well. I have a lymph node that's growing. I have fevers I can't explain. I'm losing weight. I'm very tired. These are lymphomas that typically have a symptom that prompts medical attention. They do, however, respond to chemotherapy-based treatment. And many of you probably know that the way chemotherapy works in general is by killing cells that are dividing and growing. So because these lymphomas have cells that are turning over and growing, chemotherapy is a very useful tool for the majority of patients. There are many different kinds of aggressive lymphomas, and I've listed them here. The most common one, as I showed in the pie, is diffuse large B-cell lymphoma. There's a subtype of it called high-grade B-cell lymphoma, which I'm going to talk about in a moment. So if you've heard the terms double hit or triple hit, then that is what those are referring to. There's also some other aggressive lymphomas, Burkitt lymphoma, mantle cell lymphoma, and peripheral T-cell lymphomas that I'm not going to talk about in this particular 20 minutes that I was given, but I'm more than happy to address questions at the end. So how do we treat an aggressive lymphoma? I'm going to start by first saying how we approach all lymphomas and then focus in on diffuse large B-cell lymphoma. And I'll say that the first thing that's really important for anybody on this call is to know exactly what you have. An accurate diagnosis is essential. And it's also important to know that the treatment decisions are based on histology, which means how it looks underneath the microscope, the subtype that it's named, and not the stage. So you can have somebody with an aggressive lymphoma that's a stage 2, and that is a much more serious situation often than a slow-growing lymphoma that's stage 4. So stage is less important than the actual type. We also look at how old somebody is, how fast their disease is growing, and whether or not they have any symptoms. With this in mind, the goal of treatment depends on the type of lymphoma. So for diffuse large B-cell lymphoma or Hodgkin's, the goal is cure. We know that combination chemotherapy can often lead to a cure in patients who have these diseases. If it's follicular lymphoma, this is a hallmark of a slow-growing lymphoma, and it's not technically curable, but we can control symptoms and control the disease often for many decades. T-cell lymphomas and mantle cell lymphomas are a bit of a challenge, and the goal is to get patients into remission and be able to control the disease. When we have different goals, we will tolerate different kinds of therapy that we offer to our patients. So for example, for diffuse large B-cell lymphoma and Hodgkin's, we know that the goal is cure, so we are more likely to recommend aggressive therapy, including sometimes a stem cell transplant. For people who have follicular lymphoma, the goal is symptom control, and so we usually use less intensive therapy. And when we have T-cell lymphoma or mantle cell lymphoma, two aggressive lymphomas, we often have to use aggressive chemotherapy and sometimes a stem cell transplant as part of the initial treatment. So let's turn now to diffuse large B-cell lymphoma. So diffuse large B-cell lymphoma is the most common type of lymphoma in the world. This is the prototype of aggressive lymphomas. It can occur anywhere in the body. In fact, you name a body part, and I'm sure between Dr. Stiff and myself and the other lymphoma experts on the call, we've seen it in any part of the body. There are different biologic variants, though, so that's something I'm going to talk about in just a moment. But again, the goal of treatment is cure. So one of the challenges with diffuse large B-cell lymphoma is that some patients can be cured and some patients will not have the disease go into remission right away, and sometimes it will come back multiple times. So why is this very different heterogeneity of outcome? Well, it turns out that diffuse large B-cell lymphoma is probably an umbrella term, and there are many different subtypes even within this one category. So let me start by explaining some of these different variants. One is that there's at least two different genetic fingerprints when it comes to diffuse large B-cell lymphoma. So to explain this figure, this is a biopsy sample of a diffuse large B-cell lymphoma sample. And if you look at what genes are turned on and what genes are turned off, you get a fingerprint, if you will. And this was done several decades ago and then validated in patients who had received R-CHOP. And it turns out there's at least two different fingerprints that are important. Why are they important? Because if you have fingerprint type A, which here is called germinal center B-cell-like, or this other one, activated B-cell-like, people can do differently when we use even the same therapy. So maybe we're starting to get at why one patient might be cured and the other person may have to go through multiple rounds of therapy. We don't do this fingerprinting, this gene expression profiling in clinical practice these days, but what we can do is a series of stains. This is protein stains on the tissue samples, and I just put an example of some of the names that you might see if you look at your pathology report. But essentially, these are proteins that help guide the pathologist to guess at whether or not you have fingerprint A or B, and that then tells us a little bit more about how aggressive the lymphoma is going to be. Unfortunately, there is about a 20% error rate when we do this protein staining, but it's very useful and certainly a lot cheaper than doing the gene expression profiling. Now, I know in some of the questions that we got ahead of time, people had questions about something called double hit. So let me explain what that is. This is an observation that diffuse large B-cell lymphoma, again, the most common lymphoma that we see, sometimes has chromosomes that are abnormal within the lymphoma. One of these chromosomes that can be rearranged and abnormal is called MYC. And when MYC is abnormal, it causes these cells to grow. You can think about it as putting these cells, on an accelerated phase or, pushing the gas. At the same time, many of these patients or these samples also have BCL2 rearranged. And when that's rearranged, it keeps these cells alive. So it's as if the cells are growing out of control, but instead of going through the normal death pathways, they stay alive. And that leads to something called double hit lymphoma, which makes these lymphomas very resistant to standard chemotherapy. Now, there are two different ways to look at MYC and BCL2. One is that if the genes are abnormal, then we call it double hit lymphoma. but sometimes the proteins are abnormal without the genes, and then you might see this term called dual expressor lymphoma. Patients who have dual expressor lymphoma may not do as well as people who don't have any of these abnormalities, but the outcome is not nearly as bad as it is for double hit lymphoma. And to be honest, this is an area where we don't know the best treatment. We know that R-CHOP is good, perhaps not great, but we don't know what is better. So there's a lot of trials going on to try to figure this out. My approach to aggressive B-cell lymphoma is really focusing in on diffuse large B-cell lymphoma when patients are first diagnosed, is we always test for MYC and BCL2. If, regardless of whether or not these are positive, as I was saying, we don't really know what the best treatment is, but we will give R-CHOP chemotherapy as our standard approach. And we will also consider something called central nervous system or CNS prophylaxis. The reason to include this in our approach is that we know that R-CHOP chemotherapy is very good at treating lymphoma in the body, but if there are lymphoma cells that are in the brain or the fluid around the brain, we often need to use some other type of chemotherapy that penetrates that area much better. That's called CNS prophylaxis. For high-grade B-cell lymphomas that have the chromosomes abnormal with MYC and BCL2, this is what we call double or triple hit lymphoma. And what we know here is that R-CHOP is not good enough. And there's a number of different treatments or recipes, if you will, that can be used in this setting. The one that we use here is something called dose-adjusted EPOCH-R. You'll notice it has all the same ingredients as R-CHOP, right? R-C-H-O-P, but it adds in this E, and it's given in a dose-adjusted way, which means we dial up or dial down the chemotherapy based on how an individual does. And it's also given as a continuous infusion instead of all on one day. And again, we know that these lymphomas can sometimes set up shop inside the brain, and so we always have to think about whether or not to give some type of prevention to help protect our patients. So what if the disease does not respond or comes back after this initial treatment? Well, there's several different approaches, but the standard of care today for the first, for what we call second line treatment, which means the first line R-CHOP type therapy didn't work, but it comes back, is to do something called an autologous stem cell transplant. And the way that I usually explain this is that there's four components. There's four parts to this. The first is that we have to get patients back into remission. We have to get the disease under control. We give something called salvage chemotherapy. The goal is to get the disease into remission, and there are several different examples here, and it's not really clear which one is the best, although I do think rice is the one that people use the most. The second step is to collect stem cells, and the goal is to get 4 million CD34 positive cells per body weight, and often there are some growth factors that are used to help get these stem cells collected. The third part is the actual workhorse. So this is where we, there's good data that more chemotherapy can get rid of some of the most drug-resistant cells that are there. So if they don't respond to R-CHOP, but they do respond to the salvage chemotherapy, we can give very high-dose chemotherapy, get rid of any resistant cells, and then use the stem cells that have been collected ahead of time to rescue the bone marrow from the side effects of the high-dose chemotherapy and have a second chance for cure. And I put some examples of the chemotherapy that could be used in that setting. And then finally, there is a period of recovery and re-immunizations that usually is performed over a 2-year period. Doing an autologous stem cell transplant has been the standard of care really since the mid-1990s. However, as we're going to hear in the next talk, not all patients are well served by an auto transplant. For one thing, R-CHOP is a very good therapy, and if it is not enough to get rid of the lymphoma, the whole concept of more is better is being challenged. And this is where CAR-T is really being discovered, or has been FDA approved and now being expanded in terms of where it could be best used. And that's going to be the topic of the next talk. Let's see. So what about patients where an aggressive approach like autologous stem cell transplant, CAR-T, or something else is not appropriate? And this is a significant portion of patients. Either patients may be older, or you might have organ challenges or other reasons. But if intensive treatment is not an option, I think a clinical trial is very important. However, on a positive note, we do have 3, and I put them in green, newly FDA-approved options in the last year and a half. The Pola-BR is a combination of an antibody drug conjugate, something called polatuzumab, added to bendamustine and rituximab. This is an outpatient therapy that can put patients into remission and control the disease. It is not a cure, but it is very effective in putting the lymphoma into remission. Selinexor is a tablet that can be taken that also is very effective in this setting. Again, not a cure, but can help control the disease. And just in the end of July, we had tafasitamab plus lenalidomide FDA approved. And this, again, is another option for patients where aggressive therapy is not feasible. So to summarize, lymphomas are a complex family of blood cancers. A biopsy is really important. We don't really know why lymphomas develop in most people, but it's something that I think is a really exciting area. Staging and prognosis are important, but of course it's really the type of lymphoma that's more important, and there are many new treatments that are based on better science. I put this in here. You're going to have access to my slides. This is sort of my algorithm for how we approach diffuse large B-cell lymphoma. I took out all of the clinical trials we have at the University of Chicago, but we do have 3 trials for people who are newly diagnosed. We have 1 trial here for early relapse, and we have about 4 or 5 trials for patients who might be in this category. So there's a lot of very exciting developments right now. I do think it's an encouraging time for aggressive lymphomas, and appreciate the chance to talk to you about it tonight. So with that, I'll stop and turn it over to our next speaker.
Our next presenter, we have Dr. Nasheed Hossain from the Cardinal Bernardine Cancer Center at Loyola. So Dr. Hossain, if you would like to get started and introduce yourself, that would be great.
Okay, so my job today is to tell everybody a little bit more about chimeric therapy and how this kind of falls into the treatment paradigms for aggressive lymphomas and leukemias. I have no actual potential conflicts of interest in relation to this presentation. However, I may be discussing some non-FDA approved techniques, including new models of CAR therapy for a variety of indications. So a little bit of learning objectives, a little bit of to go over during this evening's talk. A quick review of chimeric antigen receptor CAR basics. Looking at our experiences with CARs in large cell lymphoma as well as acute lymphoblastic leukemia. I talked a little bit about some of the toxicities related to CAR T therapy. Then a quick thing about what our experience has been at Loyola thus far with the CAR T cells, including our own in-house CAR T trial. And of course, after that will be questions from the audience. So why don't we get started? So, what exactly is this CAR T cell therapy? What does this mean exactly? It utilizes a gene transfer technique or techniques to reprogram a patient's own T cells. The target is defined by a customized T cell receptor, a construct that's known as the chimeric antigen receptor itself. There are a variety of ways to actually introduce this construct or this piece of code into a T cell, including using other viruses such as lentiviruses, retroviruses, also using transposons, which are those small pieces of DNA. To date, there have been many different constructs that have been developed and tested both in the lab and in clinical trials, and a variety of antigens have been targeted in a variety of diseases, including lymphoma, leukemia, and now in a growing number of solid cancers. Now, this is a very nice way to illustrate what exactly is a CAR T cell. What is a CAR construct? On the left, you have what nature has given us, our T cell receptor, which is a very intricate grouping of a variety of different molecules that act together to tell our own T cells in our body to recognize and attack foreign viruses, bacteria, etc. When certain signals are being presented to them by other cells within the body. With CAR T cells, we've taken what nature has designed and tried to simplify it down to what we think are the essential elements, including what we call a ligand binding domain, which helps the CAR T cell recognize its target of interest, and a variety of signal domains on the inner side of the cell itself that helps to tell the cell to turn on and start attacking both the tumor, but also to help to kind of turn on the rest of the immune system as well. The most common, signaling domains that we use include CD3 and the other variety of ones that are listed right here, including CD28, CD27, ICOS41BB, and OX40. So what are the exact steps that are involved in making a CAR T cell? It's a multi-step process, first starting out with a procedure called leukapheresis, where we actually take a patient's T cells and collect them from their blood using a leukapheresis machine, and then take them to the lab, where they are then treated with the vector of interest, the virus or the transposon that allows us to get that CAR construct into the patient's own T cells. This is followed by letting those T cells grow in culture, letting them expand, and then quite a lot of quality checks to kind of make sure that we know exactly what is going on. One is to make sure that there's no sign of increasing virus activity, that the virus isn't spreading or dividing on its own. To make sure that the T cells are growing well and look happy and seem to be behaving well. Also to make sure that they're actually expressing the CAR construct that we want them to be expressing before this goes into the patient. And as well at the same time, even though this is in a closed system, we also do a lot of checks to make sure there's no sign of any kind of contamination, bacterial, viral, or otherwise. Before these, T cells are then harvested, so to speak, and packaged into a infusion product that is then given to the patient, either as a fresh product or something that has been frozen and then infused, thawed and then infused to the patient, either in the clinic or in the hospital. In general, when you look at the different commercially approved products as well as the different clinical trials, the average turnaround time from the time that the T cells are collected from a patient to the time that they're infused into the patient can be anywhere from 12 to 45 days, with a variety of checks and balances in place based on being able to get enough T cells originally, and then also being able to produce enough CAR T cells that meet both the quality metrics that are in place by the FDA and different organizations to be allowed for infusion, as well as making sure that we have the dose that is intended for any specific indication. Now, what has the experience been so far with CARs in both large cell lymphoma and ALL? The current clinic experience really has centered on a couple of different trials I'm going to be going over, including the ZUMA-1 trial in non-Hodgkin's lymphoma, or large cell lymphoma, the JULIET trial, which is a different CAR looking at non-Hodgkin's lymphoma, and then the TRANSCEND trial, which is another kind of a take on CAR therapy in non-Hodgkin's lymphoma. And then kind of in combination, the ELIANA and ZUMA-3 trials, which look at both pediatric and young adult adolescent ALL, as well as the ZUMA-3 trial, which look at adult ALL. So first going to ZUMA-1. So who were the patients? The median age of patients in this trial was 58, but approximately 27 to 25, a quarter of the patients were at grade age 65 or greater. There's a slight preponderance towards male patients, and 57 patients had a good performance test, what we call our ECOG performance centers of 1 or greater. 83% of patients had stage 3 or 4 disease, and the IPI is a scoring system where the higher the score, the more aggressive the disease. About 44% of patients had a pretty, high risk IPI score, and about 70% of patients had at least received 3 or more prior lines of therapy. In addition, when you look, the number of patients who are refractory, not responding to the most recent last line of therapy they received, was about 74%. And about 65% of patients had a progression of disease or had completely actually advanced through their last line of therapy. And about 23% of patients had already undergone a autologous stem cell transplant and had either relapse of disease or progression of disease following the transplant. As far as how well it worked clinically, the overall response rate for patients treated on the ZUMA-1 trial, of the approximately 108 patients, was 83%. 58% of patients had a complete remission or no sign of disease at the time of initial disease assessment, and 25% of patients had a partial response, or at least a 50% or greater reduction in their tumor burden. What we have seen is that the responses in the patients who are maintaining an overall ongoing response is approximately 39%, 37% of CR patients, and 2% of the PR patients, or partial response patients. In general, when you look at the entire group, the overall duration of response is 11.1 months, with the caveat being that the median duration for patients who had a complete remission has not been reached, and the median overall survival is 25.8 months. Now, when we look at safety, the overall grades of the toxicities that we worry about in CAR T-cell therapy include cytokine release syndrome, which is like having the worst flu you can imagine, where the immune system is in full gear and like releasing a lot of cytokines, really causing everything to be really flared up, and neurotoxicity, which can range anywhere from having problems sleeping, feeling anxious, to as serious as having seizures or swelling of the brain. And in the ZUMA trial, 92% of patients had some degree of this cytokine release syndrome. Now, grade 3 or greater cytokine release syndrome is a cytokine release syndrome that is so significant that one has to be in a intensive care unit for closer monitoring, blood pressure support, and potentially even being on the ventilator. And in this trial, 11% of patients fit into that category, had that serious a degree of cytokine release syndrome that they developed. The time to onset from the time that they received their CAR T-cell infusion was approximately 2 days, with a range anywhere from 1 to 12 days. And it took approximately 8 days for the cytokine release syndrome to fully resolve. In contrast, for neurotoxicity, approximately 2/3 of patients, or 67% of patients, had some degree of neurotoxicity, and about 1/3, or 32%, had grade 3 or greater neurotoxicity. Usually the time to onset for this neurotoxicity was approximately 5 days, with a range anywhere from 1 to 17 days, and the time to resolution from the time of onset was approximately 2.5 weeks, or 17 days. To date, there have been 4 deaths that have been attributed to adverse events from the CAR T-cell itself. One was a patient who died of a cardiac arrest, one who had a very severe inflammatory response called HLH, one patient who had a pulmonary embolism, and one patient who had an intracranial hemorrhage. Of these 4 deaths, 2 was thought to be related to the CAR T-cell therapy itself. Now, the things to remember is, when you look at different papers or things of that sort, there are different criteria that are used for grading, and this was utilized using the lead criteria, which is becoming some derivative of which is becoming more of a more commonly utilized right now. And the CTCA is one of the guidelines we have from the FDA for grading of these neurotoxicities as well. So now let's change gears to a slightly different CAR T-cell therapy. This is from the JULIET trial. Now, this was a trial, CAR T-cell, that in contrast to the ZUMA-1 trial, used a slightly different design of CAR T-cell. Similar to ZUMA-1, which I failed to mention earlier, my apologies, this also targeted the CD19 molecule that is found on B-cell lymphomas, but had a slight alteration in the signaling domain on the inner part of the CAR T-cell itself. Now, what were the characteristics of the patients who were treated? Approximately 111 patients were enrolled on the trial. The median age for the patients was 56 years of age, and once again, about 23% of patients were age 65 or greater, and approximately 45% of patients had an ECOG performance status of 1. When you look at the different stages of disease that were enrolled on the trial, a majority of patients had stage 3 or 4 disease, approximately 76%. They also reported how many patients had involvement of the lymphoma in their bone marrow, which is approximately 7%. And a majority of these patients were diffuse large B-cell lymphoma, though a small component had large cell lymphoma that had arisen from a previous follicular or indolent lymphoma. About 27% of these patients had a double or triple hit rearrangement or a double or triple hit lymphoma. 57% were of the germinal center B cell type, and 41% were of the non-germinal center type. And a majority of patients had anywhere from 2 to 3 lines of previous therapy, making up about 75% of the entire cohort. About 45% of patients that had a relapse following their last therapy. About 55% had refractory disease. And about 49% had a previous stem cell, like an autologous stem cell transplant. We do note that this study did exclude patients who had primary mediastinal B-cell lymphoma, which is a slightly different variant of type of large B-cell lymphoma. Also excluded anybody who had had an allogeneic stem cell transplant or any patient that had active evidence of lymphoma affecting the brain or the fluid around the brain. So how well did it work clinically? The reported overall response rate for this trial was 52%, with 40% of patients having a complete remission and 12% of patients having a partial remission. At the last time of reporting, the median duration of response had not yet been reached, but the estimated progression-free survival at 12 months was 83% for those patients with a complete remission or a partial remission at 3 months following the CAR T-cell infusion. And the median overall survival has been reported at 12 months. Now, how safe was this CAR T-cell? Now, once again, we look at cytokine release syndrome and looking at the neurotoxicity rates for this CAR T-cell. 64% of patients had cytokine release syndrome. 24% of patients had grade 3 or greater cytokine release syndrome. For this CAR T-cell, the initial onset of cytokine release syndrome was approximately 3 days after the CAR T infusion, and it took approximately a week for the CRS or cytokine release syndrome to resolve. With regards to neurotoxicity, 23% of patients had some degree of neurotoxicity, and about 13% of patients had grade 3 or worse neurotoxicity. The onset of neurotoxicity was approximately 6 days, with a range of 101 to 17 days, and resolution once again was about 14 days. It took about 2 weeks for it to fully resolve. When we look at certain deaths that were reported in the trial, 3 patients died within 30 days of getting their CAR T-cell infusion, all of whom had passed away due to lymphoma progression. The investigators for this trial reported that no deaths related to the CAR therapy itself, and then to note the CRS cytokine release syndrome was graded according to a slightly different scale called the University of Pennsylvania scale. Now, let's look at a third model of CAR T cells that have been utilized in large cell lymphoma. This is the TRANSCEND trial. Difference from this is this had a slightly different constitution of CAR T cells that were being infused. And when you look at the characteristics of the patients that were enrolled, the median age was 63, with 42% of patients who were age 65 and older, and 10% who were age 75 and older. 51% of patients had large cell lymphoma, and approximately 22% of patients had lymphoma that evolved from a follicular lymphoma. About 3% of patients did have secondary, what we call secondary CNS lymphoma, or lymphoma that had initially started out in other parts of the body and had gone to the brain or the fluid around the brain. The ECOG performance status was 0 to 1, about 99% greater in patients. 38% of patients was thought to have high burden of disease at the time of enrollment. And a quarter of patients had 4 greater lines of therapy prior to the CAR T cells, and a third of patients had previously undergone a autologous stem cell transplant, and 3% of patients had actually undergone a previous allogeneic transplant. 2/3 of the patients were thought to have chemo-refractory disease, and 44% of patients had never achieved a CR with their prior therapy. And approximately 60% of patients received some kind of bridging therapy, meaning they received some kind of therapy in between the time that their T cells were collected and the CAR T cells were infused to them. Of note, 89% of patients had what the investigators characterized as high-risk features, which they postulated would portend to shorter overall survival. This included high-grade / double-hit, triple-hit lymphoma, having an ECOG performance status of 2, having primary refractory disease, being refractory to second-line or later therapy, not having a prior autologous stem cell transplant, or never having been able to successfully achieve a complete remission with prior lines of therapy. So, what was the response in the clinical efficacy with this CAR? The overall response rate was 73%, with a complete remission rate of 53% and a partial response rate of 19.5%. At 6 months, 60.4% response were ongoing, and at 12 months, 54.7% responses were ongoing. The median overall survival was 21.1 months, and the median progression-free survival was 6.8 months. So how safe was this CAR? 42% of patients had some degree of cytokine release syndrome, with only 2% of patients having grade 3 or greater cytokine release syndrome. The median time to onset of release is approximately 5 days, and the time to resolution is also approximately 5 days. With regards to neurotoxicity, approximately 30% of patients had some degree of neurotoxicity following the CAR T infusion. Approximately 10% had grade 3 or greater worse CAR T cell neurotoxicity, and the time to 9 days, and the time to resolution is approximately 11 days. They also reported how many patients had to go to the actual ICU, and about 7% of patients had to go to the intensive care unit, 4% of patients secondary to cytokine release or neurotoxicity, and 3% of patients for other reasons. They also showed some of the support for patients. For patients who had cytokine release and neurotoxicity, a majority of patients received cytokine-directed therapy as well as steroids to help calm down their cytokine release or their neurotoxicity. And then for patients who had only neurotoxicity, a majority received steroids, and some received steroids plus a cytokine-directed therapy. And they also noted that the cytokine release and neurotoxicity were reversible for a majority of patients. One patient had an unresolved neurotoxicity, which was a grade 1 tremor at the time that the investigators made this report, and 8 patients had ongoing cytokine release or neurotoxicity at time of death from other complications. Now, a little bit more about some of the safety that this trial had mentioned is a third type of side effect that we may often see with CAR T cell therapy, which is low blood counts or cytopenias. The investigators for this trial noted that 37% of patients had grade 3 or worse cytopenias. About 12% of patients had grade 3 or serious infections ranging from bacterial to fungal or viral. One lysis and had low immunoglobulin levels following their globulin levels for hypogammaglobulinemia. Now, let's switch gears to talk about how well CAR T cells have worked in patients who have acute lymphoblastic leukemia, both in the pediatric / young adult side as well as in adult ALL. First, the ELIANA trial. This was the trial looking at a CD19 T cell therapy in patients, pediatric or young adult patients with ALL. They had approximately 79 patients. The median age was 11 years of age. Most 57% of patients were male. 61% of patients had had a prior stem cell transplant, and approximately the median approximate number of therapies prior to CAR T cells was 3, with a range from anywhere from 1 to 8. 8% of patients had primary refractory disease, and 92% of patients had chemorefractory or relapse disease. They also looked at the amount of leukemia cells found in the bone marrow, and the median amount of leukemia cells in the bone marrow at the time of CAR T infusion was 74%. And then a number of patients actually had CNS involvement with their leukemia at the time of their CAR T infusion. With regards to clinical efficacy, the overall response rate for this CAR was 82%, with a complete remission rate of 62%. 66% of patients with a CR remission were in remission at 18 months beyond the CAR T infusion, and the overall survival rate was 70% at 18 months post CAR T infusion. Also of note, of the 15 of the 16 patients who did relapse had CD19 negative disease at the time of their relapse. How safe was this CAR? When we look at the experience with this trial, 77% of patients had some degree of cytokine release syndrome. 48% of these patients had grade 3 or worse cytokine release syndrome. The time to onset of cytokine release was approximately 3 days, and the time to resolution was approximately 8 days. In contrast, neurotoxicity was experienced by 40% of patients who were treated, and grade 3 or worse neurotoxicity occurred in 13% of patients. They did not report the time to onset for this neurotoxicity, but did note that the neurotoxicity usually lasted for approximately 2.5 weeks. Now, let's shift gears to what is the experience with the adults and CAR T cell therapy. Now, the ZUMA-3 trial looked at CD19-directed CAR T cells in adult ALL using a slightly different CAR than what was previously presented for the trial with the pediatric patients. They've, to date, based on their current enrollment, their overall response rate had been reported at 70%, with a CR rate of 68% and a partial response rate of 2%, with a median duration of response of 12.9 months. Safety-wise, the investigators have reported that grade 3 or worse cytokine release syndrome was experienced by 29% of patients. They did not give us very much details as far as time to onset or the median time that this CRS remained present. And with regards to neurotoxicity, 38% of patients had grade 3 or worse neurotoxicity following the CAR T cell therapy. And they've also reported 2 deaths to date on this trial, one due to a cerebral infarction and one due to multi-organ failure. Now, after having gone over these large multi-center trials, let's talk about what we have been doing here at Loyola with our cell therapy program. Working with Dr. Stiff and Dr. Nishimura, we have developed in-house have developed a CAR T cell that targets CD19, which is one of the most common antigens we see on these B-cell lymphomas and leukemias. But it has a tag that uses a human CD34 surface marker. This is unique in that it gives us the ability to both purify our infusion product, but also track the CAR T cells without engaging the CAR from patients' blood samples following CAR infusion. This CAR currently being tested in a phase 1 dose escalation trial, where our main aims right now are to determine how safe this CAR T cell is and to determine what is the maximum safe dose. Also kind of giving us an idea to see how well and how successfully we can produce this CAR T cell for a variety of patients, and getting some preliminary data as to how well it works in the clinic. This is a quick diagram of the dose escalation that we're using, where it's 3 dose levels that we're testing, initially starting at dose level 1, and with a projected enrollment of 3 patients at each dose level, with up to 6 in the 3rd dose level, barring any toxicities being experienced. And to note, all the doses that are shown are based on purified CAR T cells that are greater than 94 to 95% purity or higher. So what has our experience been thus far? We have treated 3 large B-cell lymphoma patients to date, and at day 20 and greater, the percent cytokine release syndrome for all patients has been 0, as well as the maximum crest or neurotoxicity has been 0 for all 3 patients, meaning that during the first 28 days, no patient experienced any grade of cytokine release syndrome or neurotoxicity, which compares very favorably to what has been previously reported with the other clinical trials we've been speaking about and discussing during this talk, where at least the cytokine release syndrome has been anywhere from 50 to 90%, and at least a third of patients are having some degree of neurotoxicity, this has been very encouraging for our experience thus far. To the initial overall responses, 2 patients had what we would call a favorable overall response, or 1 complete remission, 1 partial remission, and then a 3rd patient who, by the grading criteria, had stable disease, but as I will show in some of our follow-up slides, definitely had some degree of noticeable response in their tumor. Is our first patient. This is a patient who had previously been treated for a transformed large B-cell lymphoma, had actually undergone a previous autologous stem cell transplant, had relapse of disease, and was on a chemoimmunotherapy regimen prior to having progression of disease and coming onto our CAR T-cell therapy. As you can see in the first silhouette, they had quite a bit of disease at the start of the CAR T cell, prior to CAR T cell infusion, with a large number of lymph nodes in the abdomen as well as in the left ankle region. The next diagram shows their response 30 days after CAR T cell infusion, and then at 85 days at CAR T cell infusion. The dark areas that are seen in the initial scan are indicative of active lymphoma, except excluding the brain and the bladder. And then this thyroid nodule is a little bit of a red herring. This is a hyperactive nodule that this patient has that has been previously biopsied multiple times and has not lymphomas. But as you can see, even at 30 days post-CAR and then at 85 days post-CAR, the patient has had a remarkable reduction of the lymphoma to the point where they're not seeing any evidence of the lymphoma itself, showing that they're in an ongoing complete remission. And this is a colored image showing their initial sites of their cancer, including in the abdominal region. As you can see, it completely fades away after the initial at day 30 and day 85, and then inguinal lesion at day 30 and has continued to be non-active at day 85. Let's go to our second patient. Now, this was a patient with a double-hit lymphoma. Initially had been treated with chemotherapy and undergone autologous stem cell transplant, and unfortunately had relapse of disease. And thus, at the time of the initial pre-CAR infusion, had quite a bit of disease, mostly centered in the left inguinal and groin area itself. And as you can see at day 30 post the CAR T cells, it had a remarkable reduction in their overall disease status to just some small areas of activity in like the lower part of the left chest as well as that inguinal region. And when you look at the cross-sectional images of this disease burden, as you can see, there's this one little area that's lighting up this has been more or less unchanged, and then this large area of disease here that, as you can appreciate on the follow-up imaging, has shown a remarkably decrease in FDG or activity, brightness activity, and shows that a lot of the tumor is now very dark, which suggests it's just necrotic tissue. And then next we have our third patient. This is a patient that was treated for a large cell lymphoma approximately 5 years ago. Unfortunately had a relapse of disease and was put on salvage chemotherapy and then had progression of disease on the salvage chemo. As you can see, the patient has quite a bit of disease both in the chest and the abdomen. And following the chemotherapy, the CAR T-cell infusion had a remarkable decrease in their overall disease burden. When you look at the cross-sectional images of the patient's scans, the patient initially had quite a very large lymph nodes behind the heart, completely had become unreactive post-CAR T-cell therapy. They also had quite a large aggregate of lymph nodes lighting up in the abdomen, which had become completely inert on the follow-up. And then they had some areas by the spleen and by the pancreas that were lighting up that are much decreased in activity on the follow-up scan. And then this one small area in the pelvis that had some activity previously and had a similar activity. One thing to note is that the PET scan that was done initially was done using a different technique than the first one. And on reviewing with nuclear medicine, they felt as this was a more or less a stable scan, but some difference in the imaging modalities. So, in general, this has been a very exciting time for us here at Loyola. We've had some very promising results with our first 3 patients. With the lack of toxicity, we've been able to get the okay from our review board to go with the our dose level 2. So we're escalating the dose and continuing to see how well this goes, and hoping for ongoing toxicity and greater clinical efficacy. And all of this work has been in no small part due to all the support we have received for our cell therapy program from here at the Department of Medicine here at Loyola, Dr. Siv, Dr. Nishimura and his lab, as well as the Leukemia Research Foundation, and for all the patients, family, and healthcare workers who have made all of this possible. Thank you.
Okay, so I hope people can hear me now. Nash, can you shake your head if you can hear me?
Yep.
Okay, great. Thank you. And thank you to Sony. Now, you're not seeing me, you're hearing me. I'm sitting outside in the middle of nowhere. It's raining and it's cold, but I'm here and I hope you can hear me, because we're going to go through some questions now. First of all, I'd like to thank you all for being patient with me. And I'd like to thank Sony and Nash for being our speakers today. Now, I'm afraid to turn on the video for 2 reasons. Number one, I'll just be a black, dark blob. And number 2, it might decrease the ability to hear me. So let's start going through these questions. And again, to everyone, you can type your message in the chat box, which is in the lower right-hand corner. And we'll go through any additional questions that you might have. But we do have a series of questions, and as the speakers know, that I'm going to throw in some additional ones as well, hopefully not too challenging. So let's, first one is for Sony. My husband was diagnosed with a double-hit lymphoma. with follicular lymphoma, presumably to start with. Now he's in remission with our EPOC. I have heard that transform MYC gene is non-druggable mutation. What options are there for a durable remission, or is that impossible with this disease?
So first of all, thanks again to Pat, to everybody else for having me here. In terms of this particular question, when we first had information about double hit lymphoma, everything seemed quite dire. In other words, when we looked back, patients who had double hit, the outcomes that were reported in what we call retrospective databases didn't look particularly good. However, as we've expanded testing, I think it's clear that double hit lymphoma, if you don't restrict the testing just to the highest risk patients, that not everybody is going to have that very poor outcome. And so treatments such as EPOC-R and other treatments are actually quite good. I think there is still obviously room for improvement, but I do think that EPOC-R can be curative for patients with double hit and triple hit lymphoma. The question about, can we be smarter about treating this disease? In other words, not just giving chemotherapy that's more intense, but actually going after the abnormalities, of which there's MYC and there's BCL2. That has been a little bit more challenging. There is a clinical trial right now targeting BCL2 and combining it with chemotherapy. And there's, it's just early going right now. We don't know. Targeting MYC, as you've stated, can be very difficult to target. So the concept of something being undruggable means that it's a target. We know it's a bad prognostic sign, but we can't really get after that particular protein. And that is correct. Targeting MYC is very difficult. All of that being said, if somebody's in remission after EPOC-R, there's nothing more to be done. A good portion of patients may actually be in the cure category. Pat, is it okay if I answer the other part of the question? Because there's a chat question about two types of lymphoma.
Yes, please.
And that first question you just asked me, the person asked about follicular lymphoma that had transformed. So I didn't cover this because there's just, I was trying to stick to the 20 minutes, but it is true that all slow-growing lymphomas can change their behavior and turn into an aggressive lymphoma. And when that happens, we call it transformation. If CLL becomes more aggressive, we give it a special name called Richter's transformation. But any slow-growing lymphoma can transform. So with that being said, it's possible for people to have two different types of lymphoma, a slow-growing and a fast-growing. And the synonyms for that are indolent and aggressive.
Okay, thank you. The third question maybe would be, if I have a double hit lymphoma that was de novo or just came out of the blue, is that different than a double hit lymphoma that arose originally from a follicular lymphoma or transformed as far as therapy and prognosis?
Yeah, that is such a good question. So it depends on whether or not the slow growing part has required therapy. So if somebody has follicular lymphoma and got bendamustine and rituximab or CHOP rituximab and then has the transformation, that is a much harder situation than somebody who has a slow growing lymphoma, never got treated for it, and then transforms into a double hit. That latter one where you haven't had any prior therapy for the follicular does a little bit better. People who have what we call de novo, as Dr. Stiff just said, meaning that they didn't have a prior diagnosis of a slow growing, they also do better than people who have had lots of prior therapy for their slow growing.
Okay, so let's ask Nash then. We have a lot of data. A lot of it was complicated, and maybe one of the questions kind of will help in just if we can get out of you a summary. So CLL patients are eligible for CAR T, but they don't decide to do it. Why aren't they doing it? So I think some of it you kind of mentioned was the toxicity. So if I have diffuse large B-cell lymphoma and I've relapsed and my doctor says you should have CAR T therapy, what are my chances of making it out alive? What are my chances of having a remission? What are my chances of being cured, if we can say that? And how long is it going to be a treatment toxic effect? In other words, how long is the toxicity going to last?
Yeah. So, as far as for my CAR T-cell therapy condition, based on our current experience right now, I'd say approximately 40% of patients are having what we're thinking of as a durable remission from the CAR T-cell therapy itself. It can vary a little bit depending on exactly the type of CAR T-cell one is getting. The toxicity, the toxicity experience, that I've reported in the trials are based on some of the, it can seem scary at times, especially when you look at that 90% number for some of the trials. But the one thing to keep in mind is like the paradigm as far as how well we're doing as far as recognizing the signs of these toxicities and how we're treating them is undergone quite a bit of a transformation, especially in the last 2 years. And so for many times we're actually able to catch and intervene on these toxicities at a much earlier time before they've gotten to that grade 3-4 range, and able to kind of get them to get from getting any worse, with current experience showing that has no negative effect on the CAR T, the CAR T cell activity itself. Has gone through multiple lines of therapy, has had very much a refractory disease, has gone through an autologous, has gone through other transplants in the past. In general, the likelihood of them being able to get in cure with other kind of more traditional approaches, depending on what paper, what study you'd like to believe, would be anywhere from 10 to 20%, I would say. And so CAR T cells, at least right now, would give us at least some degree of an ability to further improve on that. Now, the other thing to keep in mind is, the CAR T cells that I kind of went over right now were really what we call like second generation CAR T cells. There's third, fourth, and many more of the generation CAR T cells that are kind of ongoingly being developed in the lab right now. The hope is to continue to push this forward and move that, that cure rate into a much higher, much higher percentage, and also a lot of debate as far as moving it earlier in the treatment paradigm as well. So stay tuned, I guess, would be the answer.
Okay, Sony, back to you. We're still going on folliculars. So, who is admitted with a transformed lymphoma, which basically has a large cell and a follicular component. She received R-CHOP chemotherapy. She's in remission, but obviously, I think based on the question that she's asked in the chat room, she has heard that the follicular lymphoma may come back. What should she do, and how should she be monitored and treated?
Yeah, these are really great questions. So it is correct. Oh, can you hear me?
Yes.
Okay, good. So it is true that, when we give R-CHOP chemotherapy, we can cure the fast growing part, but the follicular component is not technically something that's curable. However, it is something that's manageable for, many decades at a time for most people. However, there's a small percent of patients where if the follicular lymphoma comes back early, and by early we mean within the first 2 years, then the treatment might be a little bit different. But for most patients, when the follicular lymphoma part comes back, it's something we manage, with less intensive therapy, sometimes not even any therapy at all, just observation. The way that I try to monitor my patients is I try to avoid a lot of CT scans, especially once they're beyond the first 2 years after the R-CHOP. So I do, it's physical exams and blood work. And what I always say is if somebody looks well, feels well, has no symptoms, and has a normal exam and normal blood work, the added value of a scan is very low. So I tend to do a lot more clinical monitoring rather than the scans. So there's really no good answer as to how often somebody should be monitored, but I do try to keep the long view in mind, which is that I hope I'm taking care of somebody for, many, many decades, and try not to overdo it with the scans. But the bottom line is that if the follicular part comes back, it's usually something that we can treat in the vast majority of patients.
Thank you. Nash, there's a question here about natural killer CAR. Can you update the audience on what those are and what they're being used for, and where do we stand with that?
Definitely, yeah. So this is a very exciting new development that we're seeing in this kind of cell therapy field. As I mentioned in my talk, like the CAR T cells are really using our T lymphocytes as kind of the background cell that we're using to make these CARs. With CAR NK therapy, we're actually looking at the natural killer cells and utilizing them with a CAR construct. Certain pluses and minuses for this type of approach. One is that these are less likely to cause like graft versus host type disease, so you can actually make this without what we call allogeneic NK CARs, meaning taking them from other people besides the patient themselves and having them potentially on the shelf so that you can quickly take them off the shelf and infuse into a patient theoretically within a couple of days. The other part is that with CAR T cells, a lot of times patients will have progression of disease either because the lymphoma itself has lost the CD19 target or has otherwise altered the way that their surfaces, the surface molecules are arranged to kind of evade the CAR T cell, especially the way the CAR works. With NK cells, they have both this ability to use the CAR, but as well as intrinsic abilities to kind of sort out and seek out these tumor cells. So even if the tumor manages to evade the CAR construct itself, there's a high likelihood that the NK cell itself would still be able to tease out and attach to and attack the tumor itself. Now, NK cells have been kind of the most exciting recent trial has been from the MD Anderson group earlier this year, looking at a small cohort of 11 patients that were treated with CLL or non-Hodgkin's lymphoma, and they had some very nice, very nice responses with very little toxicity. Now, when looking at this from a larger scale, there are a couple of questions as far as where could you get the NK cells from? They're not as easy to collect as your regular T cells. Some postulated sources for NK cells have been both including getting them from cord blood units, as well as looking at cell lines that have been previously established, as well as looking at inducing like very basic stem cells to differentiate into NK cells. Now, beyond that, the other question is that the current experience is very early, and one question that always comes about with any new emerging therapy is what's the durability of response? And so, I myself am kind of waiting with bated breath to kind of see what the updates to the MD Anderson trial experiences and what other trials will show as far as, if you're having a great response in the first month or two, how long does that last? And does that hopefully last for a month to years, if not long?
Okay, Sony, little bit on the same subject. So my doctor has recommended CAR T cells, but I've seen in chat rooms and on the web that there are several new FDA-approved drugs that are producing complete remissions like CAR T cells are doing. Can you talk about those and try to be as specific as possible, and whether or not you think that those are a reasonable alternative to CAR T cells or will become a alternative to CAR T cells?
And the question is specifically about follicular or about?
No, diffuse large B cell.
Diffuse large B cell. Okay. Yeah. So the other category of drugs is something bispecific antibodies. So similar to a CAR T, these are agents or at least products that that get T cells excited, if you will, but they don't do it by engineering T cells. They do it by giving a drug that has an antibody with two heads. One head binds to CD19 usually, and the other head binds to CD3, which is on T cells. There's also some that bind to CD20, which is on the lymphoma cells, and then T cells. So the basic concept is that these bispecific antibodies have two different heads that bring together the cancer cells, the lymphoma cells, along with cells of the immune system, usually T cells. And these are very exciting. We've had a lot of very preliminary data that makes it seem that we can get people into remission. The challenge is that unlike CAR T, which looks as if once people go into remission, that's a living drug. These are T cells that are there in the person's body and can get reactivated whenever another lymphoma cell pops up. Unlike that, these bispecific antibodies seem to be much more temporary, much more similar to other treatments that we might use, like chemotherapy or other biologic agents. The side effects seem to be fairly tolerable, but it's not as durable. So I would not put it in the same category as CAR T.
Okay. Nash, the first successful use of CAR T was in chronic lymphocytic leukemia, yet there is no FDA-approved indication for CLL. Why not? And what's going on in the field of CLL and CAR T cells?
Yes. So with CAR T cells in CLL, there have been quite a bit of success with them. But one thing we've seen is that like the dose of CAR T cells seems to relate to the actual efficacy as far as getting the CLL under control. And I think the other challenge that has been, though, the guys at the NC and Penn and Fred Hutch have done quite a bit of work ongoing looking at different CAR T cell models in CLL. I think one challenge has become that there are just such a sheer number of different options for CLL patients that, there's been a kind of a back and forth as to the toxicity, where, the risk benefit ratio for undergoing a CAR T cell therapy with its CRS neurotoxicity versus going on ibrutinib or some other more directed therapy, things of that sort. And I think at the end of the day, also because of this, like the presence of so many options, there's also been, I guess, in general, maybe some less enthusiasm from the industrial side of things as far as being able to kind of further develop these along. But I think it's still something that we're still looking at. I think the next biggest thing I would say is to kind of get more patients on who have Richter's transformation. A lot of the clinical trials that I had kind of talked about during my presentation actually excluded patients who had Richter's transformation because the thought was that this is a whole different biology. If you look at more recent trials that are being established right now, they're actually reaching out, including Richter's transformation patients. And I think for those patients, especially, this might be a very, CAR T cell might be a very compelling option for a disease that otherwise may be very resistant to other approaches and therapies.
Okay, Sony, there's a question about marginal zone lymphomas. Maybe you can kind of introduce the diagnosis and how they're typically management.
Yeah. So marginal zone lymphomas are a group of lymphomas that tend to occur in non-lymph node structures. So we talk about extranodal. So often these are lymphomas that grow in the stomach or in the skin. They can be in lymph nodes, but most commonly in non-lymph node sites and also the spleen. They fall into the family of slow-growing or indolent lymphomas, and we tend to treat them with less aggressive therapy than we do the aggressive lymphomas. So often patients can get just rituximab. If it's just in one or two areas, you can use low-dose radiation. If it comes back or if it's more aggressive, you can use a combination of chemotherapy plus rituximab. And most recently, in the last year or two, ibrutinib, which belongs to a family of drugs called BTK inhibitors, has also been FDA approved. So these are, it's a different sort of subset of lymphomas. One of the more interesting things about the marginal zone lymphomas is that they often occur in response to some type of irritant. So in other words, you remember that the immune system, the B cells and the T cells are part of our immune system. And when they get irritated, in the case of marginal zone lymphoma, they can become cancerous. So it's like a bacteria stimulates them or some other antibody stimulates them. And then these B cells turn into a cancer, and it's often marginal zone lymphoma. But again, very slow growing, something that we can typically manage with less aggressive treatments.
Okay. Let's see here. We have a complicated case in the chat. Let me kind of summarize this. This is a person who donated for his younger brother who had acute leukemia. He was a stem cell donor. The brother is doing well. But recently, he's been diagnosed with a lymphopenia, or a decreased number of lymphocytes. CD5 is decreased, and his absolute cell count is 200, so low. He wants to know about not only his brother, of course, but himself at the same time. And is there a possibility that there's a familial genetic lymphoma connection?
Yeah, this is, first of all, it'd be really important to know the rest of the family history. If there's other cancers, including things like colon or breast cancer or brain cancers or kidney cancers. But I do think that we know a little bit more about blood cancers that run in families, but we're not able to really pinpoint the genes. So could there be a familial genetic lymphoma connection? I think that is a possibility, but really would require more therapy. I think the other part of the question is whether or not being the donor increased the risk of developing this CD5 positive B-cell lymphocytosis. And there, I think the answer is no. Sometimes when we give growth factors to normal donors, we worry about the myeloid cells, not the lymphoid cells, but the myeloid cells getting exposed to the growth factors. But there's no connection between being a stem cell donor and developing B-cell lymphocytosis.
Okay. Ash. Back to my original question, a patient with large lymphoma, relapse, refractory, gets CAR T cells, and has, as you said, about a 45% chance of long-term complete remission, up to 3 plus or minus years. What can we do to improve on that, if anything, or what's being done to take that remission rate and try to improve on that for those that are not in a complete remission but might be in a partial remission?
Great question. So there's been, when you look at the CAR T, cell, those of us who are doing CAR T therapy, people have to, so people may be able to have like different approaches to doing this kind of to these patients who have a partial response. One thought is to be able to say, can you further drive the response into a complete remission? Based on current trial data, about a third of patients without any intervention may potentially go from having a partial response into a complete response. But the thought now is that can you further invigorate, charge up the CAR T cells and or target the lymphoma in such a way as to kind of further drive them into a complete remission. Things that have been tried in the past include using lenalidomide with rituximab, so going after CD20 along with an immunomodulator, looking at PD-1 or PD-L1 blockade, and then now more recently there's been some talk about using other anti-CD19 drugs that may potentially look at a different epitope than the CARs recognized CD19 epitope, as well as looking at other things such as the polatuzumab that Dr. Smith had mentioned, to kind of look at other different targets that may potentially help deepen the response. The SWOG group is actually kind of looking at, developing such a proposal at this time. And the other thing I'd like to take a look, to kind of step back at is, so one thing I would like to emphasize is that, not all complete remissions are created equal. There's actually like emerging data right now looking at the whole idea of minimal residual disease for these lymphoma patients, that, your minimal residual disease status at the time that you have your initial PET scan or disease assessment around day 28 to day 30 can actually differentiate complete remissions that potentially might be more durable versus those that are not. And so, I helped to kind of organize a study with the Stanford group, like a couple of years ago before I came to Loyola, where, we've kind of seen some positive signals of that front. And then, there's some proposals underway right next, like trying to look at MRD guide therapy, further consolidation post-CAR T cell therapy. And so kind of some other exciting things that kind of looking at further, one, deepening the response for the people who have a complete remission so that they continue to have it in a durable sense, and also looking at those partial responders and maybe even stable disease responders and trying to get them into a complete remission and then maintaining them in such a state.
Okay, so we're getting close to the end here. We always get questions about non-traditional therapy or homeopathic treatments. Sony, sorry to ask you this one, but will green tea help treat or cure lymphoma? I'm not being I'm mocking here. I'm just asking because it's a question that keeps coming up over and over again. I have a patient who's COVID, and her doctor told her to take vitamin C, glutathione, vitamin D, zinc. Are any of these treatments that are out there that are claimed to be of value for lymphoma, are any of them useful? And do they impact or interfere or augment the standard therapy we give to patients?
Yeah, I mean, for one thing, I think it is something that is very commonly asked. So That whole field of complementary and alternative medicine, or CAM, is the catchword that we use for it. My approach is that these are drugs, right? So these, even if they're natural, herbs or whatever, they're still chemical compounds. They still get metabolized by the liver. They still can have their own side effects, and they can interact with the treatment that we give patients. So there is no data that any of the alternative medications affect the natural course of lymphoma. So, I think that when people are saying that something is a cure or it can help, if we just look at the quality of the data, I think there's a lot of holes you can poke in it. That being said, if it's considered safe, or there's not a whole lot of toxicity, I don't mind if my patients try it. I do not want people to be on any of these medications at the same time that they're on any kind of treatment for their lymphoma, because a lot of these herbs do get metabolized by the liver. They can induce or make the drugs we're giving more toxic. And there's lots of examples of that. So, that's a whole discussion, but I would not mix those. And I don't personally believe there's enough compelling data that they change the history of lymphoma.
Okay, so we'll let the last question to Nash, and that's the use of non-scan evaluations for disease. You did mention a little bit with minimal residual disease, et cetera. The specific question is circulating DNA for lymphoma or other tests that we could use without having to do PET or PET CT scan with the attendant radiation.
Yeah, that's a great question. So actually, circulating tumor DNA is becoming kind of a very exciting way of trying to look at and monitoring a patient's lymphoma. There's been quite a bit of work from both the NCI with Dr. Rashevsky's group, as well as the Stanford group with Dr. Ash Alizadeh and David Kurtz, as well as some of the work that I did when I was over with David Miklos, which has shown that you can actually look at circulating DNA, tumor DNA, both either looking at the B-cell receptor, unique sequences from a tumor sample, to be able to longitudinally monitor a patient's tumor burden. And we have been able to actually show in preliminary studies that you can actually be able to predict relapse before any kind of CT or PET scan. And there have been some studies underway there where we're utilizing this kind of assessment of the blood samples in between PET scans to see if we can kind of get a better idea of flagging patients who might be relapsing before they have any radiologic or clinical approach. Has been using kind of like a preset DNA, kind of a gene set profile. This has been done with Dr. Alizadeh and David Kurtz's group, where you can actually look at genes of interest in, at least in large cell lymphoma thus far, that can kind of be kind of a hallmark of the tumor burden, and they can actually be able to map out evolution of the patient's lymphoma if it does relapse, and look at targeted changes that might help determine what's driving their patient to relapse and so forth. They're still looking, kind of seeing how this can be, translated into more targetable drugs, things of that sort, but that's kind of a little bit further down the pipeline.
Okay, well, we're at the end, and I don't know if your viewers know this, but to me, it's obvious. Both of you guys are still at work. These are two of the busiest clinicians that take care of complicated lymphoma patients in the Chicagoland area. These are docs that I would personally go and have them care for me if I had lymphoma. And I really, really, really appreciate them taking their evening this evening to spread their vast knowledge with you for these topics. Please accept my kind thanks for both of you, as well as Carrie. Sorry for the twerks that we had getting me online here tonight. So with that, we'll end. There's a couple other questions that we have to do with our next series, which has to do with was a question about myelodysplastic syndrome, and there was a question about acute leukemia. And that next session is coming, I believe, in 2 weeks. I will be back in the office at that point. will be able to see and hear me. And please do ask your questions again, because these will probably hit the corner basket here. So please send your questions in again, and again, as an enticement for you to join us with this third session. So again, Sony and Nash, thank you very much.
Thank you. Thank you
so
very
much.
much.
And thank you to Dr. Stiff as well for monitoring or moderating the events and for the Q&A section. One last reminder to please complete your brief evaluation that will be emailed after the program. And once again, thank you, Dr. Smith and Dr. Hossain. Thank you all for joining us and for being patient during some of our audio troubles today, the joys of having a virtual program, I think. But thanks again, and have a wonderful evening, everyone.
Thank you. Take care.
Take care. Good day, everyone.